Welcome, everyone. In this lecture, we're going to discuss physical restraint in EMS. We will focus on how and when EMS professionals should use physical restraints on patients. We're not covering chemical restraints, like sedatives, in this session, just the hands on methods of restraining a patient for safety. Our goal is to give you practical guidance on doing this safely, legally, and effectively in the field. So, first, when is it necessary to restrain a patient? The big rule is use physical restraint only as a last resort and only to prevent someone from getting hurt. We never want to jump straight to tying someone down unless it's absolutely needed. If you can de escalate the situation or find another solution, do that first. For example, if a patient is combative because of a treatable medical issue, say their blood sugar is very low, try to treat that if you can. Sometimes when you fix the medical problem, the combativeness goes away. Or if they're just scared or confused, sometimes talking calmly can avoid the need for restraint. We'll talk more about verbal de escalation on the next slide. However, there are times when restraint is clearly needed. Indications include any scenario where the patient's behavior is so violent or unsafe that they're a danger to themselves or others. Think of a patient throwing punches at you or your partner, or trying to run into traffic, or ripping out their IVs, or endangering their own life. If someone is truly out of control and could seriously hurt themselves or the people around them, that's when you have to consider physical restraint. It's really important to remember restraints are a safety tool, not a punishment. We don't restrain people because they're being annoying or to teach them a lesson. It's purely to prevent harm. Ethically and legally, we have to use the least restrictive option that works. That means if a patient can be managed with just a couple of people holding them and maybe one arm restrained, do that instead of 4-point strapping them down, but only if it's safe. In practice, though, when patients truly require restraint, it often ends up being 4-point for full control. The point is, don't use more force or more restraint than is necessary. Patient rights still matter, even when they're combative. A competent adult technically has the right to refuse treatment. If a patient is refusing but not posing a threat, you generally can't just tie them up and take them. That would be unlawful. But if that refusal comes with them swinging an oxygen tank at your head, well, at that moment, their actions present a danger, and you are justified in restraining for safety. We operate under something called implied consent in these emergencies, essentially assuming they would consent to being restrained if they were in their right mind because it's needed to protect life. But we have to be very sure that it truly is necessary. I always ask myself, am I doing this for the patient's benefit and safety or for my convenience? It must always be for safety. So, bottom line, restrain only when you have to. Danger to self or others? Yes. Otherwise, keep the straps in the bag. Often, you can head off the need for restraints by using good verbal de escalation techniques. All of us in EMS should have some verbal judo skills. That means the ability to talk to an agitated person and calm them down. The first and best tool in any agitation situation is your voice. Sometimes just introducing yourself, speaking in a calm tone, and showing empathy can diffuse a situation enough that you never have to get hands on. A big part of verbal de escalation is your body language. Remember, patients pick up on nonverbal cues. If you stand over someone, arms crossed, looking stern, an already paranoid or angry patient might feel threatened. Try to appear relaxed and non threatening. Keep your hands visible and open, maybe at your sides, and if possible, get down to their eye level instead of towering above. I often crouch or sit at a safe distance, so I'm not intimidatingly close. Avoid fixed, intense eye contact. You don't want to stare them down like you're challenging them. Instead, maintain a normal gaze. Too little eye contact can seem shifty. Too much can seem aggressive, so find a balance. And watch your tone. Speak in a controlled, low tone. If you sound panicked or angry, it will feed their panic or anger. Another tip: really listen to the patient. Often they are shouting or ranting because they feel ignored or scared. Let them know you hear them. I get it, you're upset. Even if their concern seems irrational, validating that you hear them can build a bit of rapport. For instance, I see you're scared that we're going to hurt you. I promise that's not our intent. We're here to help. It doesn't always work, but sometimes a little empathy goes a long way. Of course, talking doesn't always solve the problem. If the patient continues to escalate, maybe they start picking up objects or their threats get worse, you might calmly set some limits. For example, we want to help you, but we need you to stop trying to hit us. If you can't, we may have to restrain you to keep everyone safe. You're giving a fair warning. You'd be surprised. Occasionally, a patient might actually pause and negotiate rather than be restrained. They might say, okay, I'll calm down, just don't tie me up. And if they truly do settle, great. Then you won't need the restraints. But if they continue to be a threat, at least you gave them a chance. If it's become clear that verbal techniques aren't working and the patient is a danger, you need to plan a physical restraint. Don't go in solo. Even a small framed patient can overpower us if they're determined or under the influence of drugs. People can have surprising strength when agitated or in fight or flight mode, so ensure you have enough people. Ideally, we want one person for each limb and one for the head, so 5 people total as a minimum in a perfect world. Some references say 6 people, one for each limb, one for the head, and one to assist or rotate out. Realistically, you might not have that many. At bare minimum, you should have at least 3, 2 holding arms, one holding legs, and that is really low. 4 or 5 is much safer. This usually means calling for backup. If it's an EMS only response, call another ambulance or fire crew. In many cases, though, the police will be involved for violent patients. Don't hesitate to get law enforcement on scene early if a patient is becoming combative. They are trained for these situations and can provide manpower and presence. Before you actually engage, have a plan. Communicate with your team or partner. Typically, one person, often the most senior or the one who recognized the need, will take charge as the team leader. That leader should quickly assign roles. Okay, John, you take the right arm. Sarah, you get the left arm. I'll get the legs. Tim, you manage the head. And importantly, plan how you'll approach. Often a good plan is to have 2 people approach from either side of the patient, one from the left, one from the right, so the patient can't focus on both at once. If the patient is seated, sometimes one person can distract from the front while others come from behind. But the key is doing it simultaneously. You don't want a staggered attempt where you grab an arm and then 5 seconds later, someone goes for the legs. That gives the patient time to fight back one limb at a time. The team leader might say, "On my count of 3, we move in." And you do. 1, 2, 3, go. Coordination makes a huge difference. While planning, survey the environment. Remove any potential weapons in the patient's reach. This could be something like scissors, oxygen cylinders, even car keys, anything that could be swung or thrown. Also consider space. If you're in a tight bathroom or a kitchen with knives around, for instance, try to guide the patient, verbally, into a safer area before initiating the restraint if you can. Safety of your crew is paramount. If a scene is too dangerous, say the patient has a firearm or knife, your protocol likely says withdraw and wait for police. As you gear up to restrain, put on gloves at a minimum. Combative patients often spit, scratch, or there might be blood if they've self-injured or broken something. Eye protection is a good idea if available, because getting spit or blood in your eyes is a real risk. If you know the patient has a history of spitting, maybe from dispatch info or initial interaction, you might even have a simple surgical mask ready to pop on them once you engage, but only if it doesn't delay or complicate the takedown. We'll talk about spit hoods in a bit. A note on personnel composition. If possible, have at least one person of the same gender as the patient involved. This can help in a couple ways. For one, a female patient might be less terrified or offended if a female responder is helping rather than all males, and vice versa. Also, if any clothing has to be removed or there are privacy concerns, same gender providers can reduce later allegations of impropriety. It's not always possible, but it's a consideration. Also, designate someone, often the team leader or another, to keep talking to the patient during the restraint attempt. This person's job is to continue the de-escalation effort even as the team moves in. They might say things like, "It's okay, we don't want to hurt you," right up to the moment of action. This can serve as a distraction and also hopefully make the patient slightly less actively resistant at the exact second you move. If law enforcement is on scene, coordinate with them. Typically, police can help by controlling limbs or applying handcuffs if that's part of the plan. Just note, handcuffs are not the best for patient safety, but sometimes they're applied in the heat of controlling someone. If police do cuff the patient, they really should ride with you or follow closely behind to the hospital, because if something happens, like the patient in cuffs needs to be uncuffed for CPR, an officer should be the one handling their restraints. In general, it's better for EMS to use our soft restraints once we have the patient subdued and get the cuffs off if possible, with police permission, of course, but never remove police restraints without police there. All right, so we have backup on scene, roles assigned, plan communicated. Next comes the actual act of restraining, which is where technique is crucial. Now the team moves in to physically restrain the patient. The approach should be rapid and coordinated. On the agreed signal, like a count of 3 or a code word, everyone goes at once. Each person focuses on securing their assigned limb. The goal is to overwhelm the patient with control in one decisive move, rather than a prolonged struggle. If the patient is standing or sitting somewhere unsafe, sometimes you have to first move them to the ground or stretcher. Do this carefully. Protect their head. We're not body slamming people here. Think of it as a controlled guide to the floor. Often one technique is for 2 people to grab the upper body and sort of spiral down to the ground. Another is literally picking the patient up. with enough helpers and placing them onto the stretcher. It really depends on the situation. Always avoid dropping someone or letting their head whack into the floor or wall, then we've caused an injury. Now, positioning. Once we have control, we must get the patient lying down, supine, or semi-Fowlers. These two positions are non-negotiable for safety. We never want to transport a patient face down or with their hands tied behind them. Those positions can impair breathing and have led to deaths by positional asphyxia. If for some reason supine or semi-Fowlers is not immediately achievable, lateral is the next best temporarily. But absolutely avoid prone at all costs for an agitated patient. Once they're on the stretcher or backboard, if there was trauma, supine or semi-Fowlers, we immediately secure them. Restrain all four limbs. This usually means using soft restraints on both wrists and both ankles. Soft restraints can be commercial straps with Velcro or buckles, or even improvise with cravats, triangular bandages, or gauze rolls if you have to. The key is they should be broad and padded enough not to cut into the skin. Each limb gets tied to a sturdy part of the stretcher frame or backboard. For arms, usually we secure them at approximately waist level or a bit higher on the stretcher frame. There's a detail some guidelines mention: one arm up, one arm down. This means you might secure one arm above the patient's head and the other by their side. The idea is it limits their ability to leverage themselves to break free or to roll. It's not always practical, but if you have a long backboard, you could do that configuration. One wrist to a board corner near the head, the other to a side near the waist. On an ambulance stretcher, usually both arms end up at the sides tied to the rails. Likewise, both legs need to be secured. Typically, bind the ankles to the lower frame or the backboard if one's under them. Some use two-point restraint on legs, like tying thighs and ankles. But minimally, ankle restraints are needed because a patient can kick very hard. And trust me, a kick to the face while you're managing the patient is no fun. In addition to limbs, we use the regular stretcher straps or additional belts as chest and leg straps. You want to strap across the upper chest, above the mid-abdomen, ideally over the shoulders or high chest. This keeps the torso down, but be careful it's not so low that it interferes with breathing motion. And another strap across the thighs or hips to prevent the patient from bucking their hips up. These essentially make it a 5-point restraint, 4 limbs plus 1 across body. While applying restraints, use minimal necessary force. We're not there to inflict pain, just to secure. Don't wrench the patient's arms or legs in a cruel way. Just get control and hold. If you have enough people, each person can focus on gently but firmly controlling one limb. Avoid things like putting a knee on the patient's back or head. That can cause serious injury and looks really bad too. Once the limb restraints are on, check that they are snug but not overly tight. A good rule is you should be able to fit a couple of fingers under the restraint. If you cut off their circulation, you've created a new problem. Do not forget to continually monitor their PMS in all limbs. One challenge: spitting and biting. Some patients spit at rescuers or try to bite. This is where something like a spit hood can be used. A spit hood is a mesh net that goes over the patient's head to contain spit. Police often carry them. If you have one and the patient is a known spitter, once you've got control of the head, you can apply it. Alternatively, a simple solution is a NRB mask on their face. Make sure the O2 is on, or a surgical mask to at least block spit. Just ensure whatever you put on their face doesn't obstruct their breathing. Never gag a patient or tape their mouth. That's dangerous, cruel, and illegal. So, at this point, our hypothetical patient is now restrained supine on the stretcher, arms and legs secure, maybe a spit mask on, chest and leg straps on. The immediate physical struggle should be over, but our job is not over. In fact, now the critical phase of monitoring begins, which is what the next slide is about. The moment a patient is restrained, we actually take on a greater level of responsibility for their well-being. Think about it. When someone's tied down, they can't adjust their position, they can't protect their own airway, they can't tell you if something's wrong as easily, especially if they're delirious. So we have to be extremely vigilant after we've got them restrained. First rule here: a restrained patient must never be left alone. One of us has to be watching them at all times. In the back of the ambulance, that's obviously the case. But even on scene, if a patient is restrained, waiting for a stretcher or something, do not leave them unattended even for a moment. It sounds obvious, but it's worth emphasizing. Leaving a restrained person alone could be fatal if they vomit or choke. Now, airway and breathing are top priorities. Because the patient is likely either exhausted from struggling or maybe under the influence of something, they could vomit or their level of consciousness could change quickly. You, as the attending provider, should ideally position yourself at the patient's head or upper body to monitor airway. Keep the patient's head in a neutral position, not hyperflexed forward. If they're spitting and you put a mask or hood on, be extra cautious about their airway patency. Listen to their breathing. Is it fast, slow, labored? Use end tidal CO2 monitoring if you have it, especially if any sedation was used or the patient is at risk of respiratory depression. Placing all of these patients on O2, even through a nasal cannula, is not a bad idea. Vomiting is a big concern. Agitated patients who've been drinking or taking drugs often vomit. We have to be ready to immediately turn them on their side if they start throwing up despite all the straps. Typically, you'd quickly remove the chest strap and roll them onto one side to clear the vomit. Always have suction prepared. Before you even start transport, ensure suction is working and within reach. If you hear the patient retching or see them gagging, act fast. We don't want them aspirating. Next, circulation checks. The struggle and the restraints themselves can affect circulation. Every few minutes, feel for a pulse in each restrained arm and leg, radial pulses at the wrist, dorsalis pedis or posterior tibial at the ankles. Also check cap refill or the temperature of their hands and feet. If anything is cool, swollen, or pulseless, you may have tied something too tight or the patient could be in shock for some other reason. You'd loosen or adjust restraints if needed to alleviate that. Typically, we aim to check these at least every 5 minutes, which often coincides with our general vital sign reassessment in a critical patient. Speaking of vitals, get a full set as soon as it's safe to do so. Sometimes during the initial fight you can't, but once the patient is down, try to get blood pressure, heart rate, respiratory rate, oxygen saturation, and a blood glucose. And keep monitoring vitals frequently. This patient is not stable just because they're tied up. If anything, they might be at higher risk now for things like dysrhythmias, acidosis, etc. If you have a cardiac monitor and it's feasible, put it on. Many agitated patients could have medical issues underlying, like a drug induced dysrhythmia. Also, put on a pulse oximeter if you can. It might be hard if they're thrashing, but as they hopefully calm down, you can get these on. Continuous monitoring is ideal. Another aspect of monitoring is the patient's mental status and behavior. Just because they were combative doesn't mean they'll stay that way the whole time. They might actually exhaust themselves and start to calm, or conversely, they might escalate further. You need to gauge that. Keep talking to them reassuringly. You're restrained for now because we want to keep you safe. We'll take these off as soon as we can, okay? Even if they curse you out in response, maintaining that compassionate tone is important. It shows anyone observing and reminds the patient on some level that you're the good guys, not their enemy. If the patient complains like, my hands are numb or you're hurting me, take those complaints seriously. Check the limb, check the restraint tightness. Maybe their hand is numb because of how you positioned their arm. You might need to adjust it slightly. Of course, some will just yell anything to get free, but still do due diligence and make sure you're not actually causing harm. All the while, ensure you, as the provider, are safe in the back. It's a bit of a dance because you need to be belted in for your own safety during transport, but you also might need to be up at the patient's head managing the airway. Try to position yourself so you can do both. Sit bench with a seatbelt around you and still lean toward the patient. Just be cautious. A restrained patient can still headbutt or spit or kick, depending on how well you restrained. So, watch your face and body positioning. If at any point the patient significantly deteriorates, say they stop breathing or lose pulse, obviously immediately stop the ambulance, undo their restraints as necessary, and begin appropriate resuscitation. It's rare, but it has happened in excited delirium cases that a patient suddenly goes into cardiac arrest after a fierce struggle. You have to be ready for that. So, monitoring is about being proactive and very attentive. The fight might be over, but now the medical management continues vigorously. Keep reassessing and talking to the patient. Also, keep your documentation notes in mind. You might even verbalize to your partner for later. Let's remember to note that at 14:35, patient was placed in restraints and vitals. At 14:40 were X, Y. It's hard to write while restraining someone, but maybe after things settle, you can jot key points. We will end the first part of this lecture here. Join me in the next to discuss the possible risks and what proper documentation looks like. See you then.